ophthalmology, they're all like super nice. And same with anesthetics, they're all like a really nice bunch of people, but surgeons, like sometimes they're nice, but you never know.
I know. Yeah, I totally get that.
Yeah. Has anyone else come as well yet, or shall I wait until maybe 5 past?
I think there's one more person in here now. I think Dave's here.
Oh, okay.
Oh yeah, hi guys.
There he is.
Hey. I think I remember your voice from last time as well. We did you. I think you asked the question about hyphema or like the anterior uveitis. There was a thing about
yeah, I did. Yeah.
Yeah.
This is the like sum total of my. Yeah, sorry, is this sum total of my ophthalmology teaching? So
that's completely fair enough, honestly.
Pressure's on, mate. Pressure's on.
What jobs do you have? Do you know what jobs you got for your F1, F2 yet? Or
not yet, no.
Okay. Do you know what you want to do career-wise?
Oh, yeah, not. We'll see. We'll see.
Fair. I'm trying to convince someone to do ophthalmology. That's my objective. Out of the two of you.
Might have to be you, Dave. I don't like the squishiness.
I enjoyed ENT more than I thought I would.
ENT's cool.
I really like the ENT as well. That's the one specialty that I really enjoyed.
Yeah. It just, I mean, yeah, you were saying, you know, how ophthalmologists and anaesthetists tend to be really happy. I found the ENT lot really happy. Like they were just like
definitely
so happy. Like it's probably just because their level of emergencies they have to deal with is so low. So it's like
exactly.
Oh, it's quite cool. Just gives you a chance to think.
It's literally like a 9 to 5 job for a lot of them, you know, like they do their clinics and surgery. And I think for me, ward round is my least favorite part of the whole process as well. So I like the idea of clinic and surgery being your 2 sessions.
Yeah, you don't get ophthalmology ward rounds, do you?
Exactly, yeah. And when they're admitted under medicine, so. Cool, I'll wait until 5 past and then I'll crack on. Oh yeah, and could you guys please do the feedback form that Catherine Stringer sends you guys, because I need to submit it as part of my portfolio, just to say that. And honestly, like if anything I can improve, like feel free to let me know.
Sure.
Definitely. Sorry, I definitely think I forgot to do it last time, but I'll do them for both sessions after this, I promise.
Amazing, thank you. Cool, I'll just start now actually. So this is ophthalmology part 2. So I thought this time I'd start with actually going through the anatomy. I didn't want to kind of patronize you guys last time, but I think actually it's just useful to kind of get that before you start. So there are 3 layers of the eye. The first layer is called the fibrous layer, and on the back you've got the sclera, and on the front you've got the cornea. The middle layer is the vascular layer, and on the back you've got the choroid, and on the front it goes to the iris and the ciliary body. And an internal layer is the retina, and then here, just next optic nerve is the foveus. That's the area with the most cones of the eye. And then you've got this bit is the anterior chamber, just next to the cornea, and then just behind it you've got the posterior chamber, so where the lens is and the iris, and then this whole thing is where they've got the vitreous humor or vitreous chamber. Can you see my mouse as well as I'm kind of pointing to stuff?
Yeah.
Okay, cool. So I just thought I'd say, look, so you guys can have a look at some of the names of red eye before I kind of go through the scenarios. So painful red eye is things like glaucoma, scleritis, uveitis. So another name for this middle layer is the uvea. And on the back of it, you've got the choroid, and on the front, as I mentioned, you've got the iris and the ciliary body. And basically when you've got an anterior uveitis, it's inflammation literally anatomically of the iris and the ciliary body, and you can get a posterior uveitis, which is inflammation of the choroid. So that's why it's worth just kind of knowing anatomy as well. The corneal abrasion, corneal ulcer, so that's literally this bit at the front, the cornea. Chemical burns, not something I'm going to cover today, but I've just posted a link to Geeky Medics. They've got a really good article like foreign bodies and chemical burns. Endophthalmitis, that's an eye infection, most commonly after surgery. Keratitis, so kera is referring to the cornea, so it's inflammation of the cornea secondary to a viral infection. Episcleritis, so that's similar to scleritis, but it's the membrane on top, the episcleral membrane. Conjunctivitis and blepharitis we did last time, and also dry eye can cause red eye as well. So first case, You're an F1 on the COVID ward, and a 43-year-old female patient with a background of UC has noted her right eye has been red for a couple of days and it's been tearing up. She also finds the light on the wards quite bright and the eye feels a little bit sore. On examination, there's a patch of redness. The pupils are otherwise equal and reactive to light. The visual acuity is 6 out of 6. Do you guys know what 6 out of 6 means?
Is that when you see at 6 meters what you're meant to see at 6 meters?
Exactly, that's exactly right. And in ED, for example, you can even get an app on your phone where it kind of tells you when you're standing at 6 meters, you can do it that way if you don't have a Snellen chart. So with this case, I'll tell you like the key points are things like the sectoral inflammation, red eye, and it feels a bit sore but not too bad. To go through these, if you had to guess one, and again, there's no pressure, it's only 2 of you, so just feel free to just take a stab. What do you think it might be?
Uveitis?
So this one's actually scleritis or episcleritis.
Okay.
And basically it's usually idiopathic, but 30% can be associated with inflammatory conditions like rheumatoid, and it can present with acute redness, which is importantly sectoral, so it's not like that whole eye being red like this conjunctivitis. And then also it's in this case it's the vessels are quite superficial, so what that means is because it's the episcleral membrane, it's not like so the way I always think about it in medicine is like when something's at the top anatomically it's not as bad as something at the bottom, so like a superficial wound infection is not as bad as like a deep wound infection. So in the same way, like episcleritis, it's the top layer, so it's not quite as bad as scleritis. And so what you can do to check for it, because it's an important distinction to make, is it episcleritis or scleritis, is you can apply some topical anesthesia and literally just like nudge it with some cotton wool. And if the vessels move, then it's more likely to be superficial, so it's episcleritis. And also, if you put a phenylephrine drop, episcleritis will blanch, whereas scleritis won't. So the way you treat episcleritis is it's self-limiting, and you topical lubricants, but sometimes you do need steroids as well. That's in comparison to scleritis, which is more commonly associated with rheumatological conditions, and it can be because of post-op or infections as well. And it's more of it's a dull eye pain. It can cause headaches, eye watering, and it's painful eye movement. So it's basically just a bit more severe, and it gets worse as you get a flare-up of rheumatoid conditions. And the affected area, to me, that looks a bit worse as well than the episcleritis. And it's kind of a deep pinkish color that's tender when you touch it. And the vessels are dilated. And actually, because it can recur, you can get kind of thinning of the sclera as well, and of the membrane. So you kind of see the underlying choroid, which is why it looks more purpley than the other one. So in this case, you treat the underlying cause. And usually as the thing goes away, the scleritis will go away as well. But use an urgent referral. Sorry, Dave, did you have a question earlier? Or?
No, that's fine.
Okay, cool. So yeah, just to again go through the differences. So episcleritis is sore, gritty, but it's often asymptomatic. Scleritis is painful. They're both linked to inflammatory conditions. In this one, you see dilated red vessels. In this one, it's a bit more pink. Episcleritis is benign, whereas scleritis is sight-threatening. So that's quite an important distinction to make. Episcleritis goes away by itself, where scleritis needs treatment. And then again, episcleritis is often more sectoral, whereas in scleritis it's diffuse and you can get necrosis as well. So this second one, a 32-year-old male with ankylosing spondylitis presents with a red, painful left eye, which is sensitive to light. On examination, you see quite an irregular pupil and also an inferior settled layer of pus and a circumciliary injection. So what that means is there's a little red rim around the iris itself. So what do you think the diagnosis is in this case?
Would this be, just kidding, would this be uveitis?
Yes, so this one is uveitis, specifically acute anterior uveitis. So there's a whole shopping list of things that can cause it, and that's kind of why it's quite important to, if you diagnose it, then to kind of investigate for these other things, or at least ask screening questions. So you might say, has there been any joint pain for someone with psoriatic arthritis, or any, back pain for someone with ankylosing spondylitis? Check for IBD, sarcoidosis. Behçet's disease is it causes mucosal problems, so you might get ulcers in it as well, and you can get a lot of viral and bacterial causes of it. It's most commonly young white male, so it's the same as ankylosing spondylitis. Signs and symptoms again: red, painful, watery, photophobic eyes. Visual acuity is mildly reduced. You can get a hypopyon, which we talked about last time, which is an inferior settled layer of pus, so it's white cells and debris. And then it can get a cloudy view. So when there are cells in the anterior chamber, it can kind of make the eye look a bit hazy. And also, as I mentioned, the circumciliary injections. So this is basically where you just get redness around the rim of the iris rather than the entire eye looking red. When ophthalmologist has a look, they'll see things like cells and flare, but kind of from your point of view, you might also see keratic precipitates as well. So that's kind of just these kind of dots of inflammatory cells all across the eye. And then in terms of management, it depends on the type of uveitis, when it's secondary infection, and when it's likely to affect sight. So I've only talked about acute anterior uveitis because it's the most common and the one you actually like. It'll be worth knowing in an acute situation, but there are obviously lots of other types like posterior uveitis. And the treatment is usually a slow tapering regime of topical steroids, and you can give cycloplegics. So these kind of paralyze the eye and don't allow it to dilate, and that helps pain basically. And if it's really bad, you can give immunosuppression as well. So case 4, 24-year-old PhD student is changing their eyes, changing their contacts when suddenly their right eye starts hurting worse than it ever has before. The eye also starts tearing, becomes a bit red. His vision is 6/9 in the right and 6/6 in the left. You put some fluorescent drop in the right eye, and you take out your trusty direct ophthalmoscope and shine the cobalt blue light on the eye, and this is what you see on the picture. So what do you think the diagnosis is in this case?
Is it like a corneal abrasion?
Yeah, so this one's a corneal abrasion. So this is basically a break in the epithelial surface of the cornea. So similar to having a graze on your skin, and it's most commonly secondary to trauma. So someone literally poking their eye, or a gust of wind, or changing contact lenses, or foreign bodies as well, and it causes a really severe pain. It's pretty much instantaneous. So as soon as you touch it, they can be like in a lot of pain because the sensory innervation to it is like quite a lot, because it's the trigeminal nerve, and just even the most small abrasion can just cause a lot of pain. But fortunately, it's self-limiting. It goes away within 24-48 hours by itself, so it's more symptomatic treatment. The way you diagnose it, as I mentioned, is put the fluorescent drops in, and you'll see it under cobalt light. It's generally something ophthalmologists would do, but if you're in like a developing country, for example, this is 100% something that you could do. And then in terms of the treatment, prophylactic chloramphenicol ointment. So the main thing you want to do is reduce the risk of a superadded bacterial infection. And instead of giving drops, you can give an ointment, which kind of sits on the eye longer, and it can kind of have a lubricant effect as well. The main thing is to avoid the use of contact lenses until the abrasion is healed. And if there's a suspicion to penetrating eye injury, chemical injury, or retained foreign body, then they need urgent referral.
How would you know when the abrasion's healed? Would you ask them to come back in order to assess that, or would you just give a time frame?
Yeah, just give a time frame of like 24-48 hours, and just really reassure them that it will go away. If you're happy with the diagnosis, then there's no reason it wouldn't go away, unless you think there's an infection, which is what we'll come on to next. So basically, a corneal abrasion can develop to a corneal ulcer. So this is basically where a pathogen actually infiltrates the epithelium as well. So it can happen. It can happen straight in terms of like direct injury, but also it can happen kind of systemically as well. So things like Neisseria and Haemophilus can cause it. Also, someone who's wearing contact lenses for a prolonged period of time, unfortunately, if it's not completely clean, then the contact lenses themselves can become cornealized, and they can infect small abrasions. So initially, it presents similar to a corneal abrasion, but the vision can be affected if it encroaches the visual axis. So it's not a peripheral one; it's near the center of the eye. And also on examination, you'll see kind of a staining epithelial defect. So it's like fluffy and irregular. So you can kind of see it there. and it's difficult to appreciate, but there's a few smaller ones next to it as well. So this one, you will take a swab to look for infection, or also a corneal scrape. So literally just scrape the bit that looks where the pathology is to identify the causative organism. Also, and obviously it's essential to identify the infective organism to treat it accordingly. And severe corneal ulcers may require admission for antibiotics. You give mydriatic drops to dilate the eye. And it's another emergency because if it's untreated, then it can cause permanent scarring. So also viral keratitis. So this is the most common cause of keratitis, and it's usually caused by HSV or varicella zoster. So you might get a patient who comes in with something like coexisting, shingles or ophthalmic shingles or a cold sore, and they also have some eye pain, and in that case, it would, point to something like keratitis. Again, symptoms are similar to corneal ulcers. And in this one, you see quite a cool pattern where you do the same thing, the fluorescent staining and the cobalt blue light, and you get what this thing is, the dendritic epithelial defect. So it looks like a bit like a dendritic cell, and you get associated inflammation. So in this case, you give topical antivirals and again refer to ophthalmology. So this next case, a 43-year-old Filipino nurse presents with a right-sided headache, right-sided eye pain, vomiting, and red eye. On examination, the pupil is non-reactive and the circumcorneal injection and a hazy cornea. What's the most important diagnosis to rule out?
Would you always want to rule out angle closure glaucoma?
Yep, exactly. Perfect. I think that was like the one thing I was hoping that if someone gets it before I say. So I'm glad that you got that one. So this is a condition of acute raised intraocular pressure with a physically obstructed anterior chamber angle. So this angle basically refers to the fact you've got the cornea like this, and then you've got the iris that comes like this. So it's literally an angle, an acute angle. And then when there's an obstruction of drainage, the angle becomes more acute. So the iridocorneal angle, and this means you get more aqueous fluid inside the anterior chamber itself, and that causes the intraocular pressure to rise. So this would present with pain, headache, nausea, vomiting. So it's kind of more systemic symptoms. As in opposed to just the eye, it's kind of more around the eye, and also reduced visual acuity and photophobia. On examination, you get a hazy cornea. So this is because when you've got an accumulation of all that fluid, it means that the cornea is more hazy, so it's not as clear. And then importantly, you get a mid-dilated, unreactive pupil. So that's kind of it's one of the key signs of angle closure glaucoma. So in terms of assessing someone where you're a bit worried that they've got it, what you can do before treating them and referring them is actually lie the patient on their back. So if you think of the eye, so if this is someone's eye, and let's imagine this person's got glaucoma, then if you literally turn the eye 90 degrees, if you were lying them on their back, then that literally causes the lens to fall because of gravity, so it makes the angle less acute. So it's kind of something you can do before actually initiating treatment. Did that make sense?
No, I didn't quite get that. Say again.
Oh no, fair enough.
Would you mind just
Yeah, of course. So basically, if you've got so the angle closure is happening between this kind of transverse angle, this transverse line, i.e. the iris and the lens, and this more oblique angle, which is this cornea, and that's the acute angle right there, which is the one that gets worse and causes the pain. But if you literally lie someone on their back, then the lens drops down, and then because it drops down, the angle becomes less acute. So that so that's the kind of first thing you can do. But then this one requires an urgent referral to ophthalmology, and there's numerous things that they can do for that. They might do it themselves. They might recommend for you to prescribe it. So systemic pressure reducing agents, so things like acetazolamide. So this is a class of diuretic that's not that effective in kind of systemic functions, but in terms of reducing intraocular pressure, it can be quite effective at reducing the pressure. and then also topical beta blockers. So this can decrease the secretion of aqueous fluid. So one of them brings the pressure down, one of them reduces the secretion in the first place. And then meiotic. So meiotic means to make the eye more constricted. And then this basically opens the angles again. So again, if you think of this lens being smaller, then it means that it's going to be less of an acute angle. So again, it's all having a good understanding of the anatomy really helps to understand this stuff. And then in terms of the treatment, you can do a peripheral iridotomy. So that's basically shining a laser right here and basically making a big hole through which the fluid can like naturally drain. So it's like creating a new channel where the fluid can drain through, rather than just being stuck here at the canal of Schlemm, which is where the fluid can't get through. So that's pretty much everything. I thought it might be a bit much to kind of cover foreign body and chemical injury as well. So I've put the link for Geeky Medics. And yeah, I'll send you guys both the slides if you like as well. I'm happy to do that.
That's
yeah.
the question.
Yeah.
So we understand the mechanism of angle closure glaucoma.
Yeah.
Last week we had some in-person like foundation teaching on ophthalmology as well, and they were talking about open angle glaucoma.
Yeah.
And I haven't quite understood the difference. Is open angle glaucoma essentially just the chronic version where the angles aren't completely shut yet, or like I don't quite understand how they're different.
Yeah. So yes, that's in a way that's correct, because acute angle closure glaucoma is when like things have got to the extreme where the angle is really acute and the pressure is really high. That's why it's an emergency, and that's why it needs emergency treatment. So yes, the most common form of chronic angle glaucoma is the one that you describe, which is, you know, where it's like a bit less acute, a bit less pressure, but it, you know, it could become an acute angle later. But the thing about glaucoma is there's so many different types, and there's some where you can actually get it with a normal tension glaucoma as well. So you can get some with a normal intraocular pressure, normal angles. Their eye looks normal, but like just clinically, in terms of their signs of having, you know, reduced visual fields, it's still glaucoma. So that's why when they define glaucoma, it actually is technically a pathology of the optic nerve. That is what glaucoma is. To say it's to do with intraocular pressure kind of discounts the other forms of glaucoma. But so in summary, can I answer your question, is just the most common form of chronic angle is just like a watered down version of acute angle, but you can get other types as well where the intraocular pressure is normal and the angles are normal as well.
Okay, and then sorry to latch on to that. How does anything to do in your anterior chamber then connect to the optic nerve? Because I remember they were talking about like the disc ratios and something, and I was just completely lost because I just don't understand how anything with the pressure or not pressure in the front has anything to do with the back of the eye. I don't know. That's really a dim question. Sorry.
No, that's a good question. I don't know, to be honest. I hadn't really thought about it. I'll ask one of my friends and then send you guys an email, actually.
Thank you.
That'd be really helpful.
Yeah.
I feel like if you don't know, I don't need to know, so that's fine.
Oh, no, that is quite interesting. I think it will be, I suspect it will be something to do with ischemia, where like there's more pressure in the eye, which causes ischemia to the optic nerve, but not entirely sure. What do you, how are the rest of the cases? Any questions about anything else? I feel like I went a bit quickly, actually. Anything else? Any other questions about like episcleritis?
I just have another question about the acute angle glaucoma, if that's okay.
Yeah.
It might be a really stupid question again, but what causes I appreciate if it's on a background of kind of like chronic, you know, like inability to drain and all that, but if it's acute just on its own, what causes it suddenly to become blocked in terms of drainage? What's the what is there like a main mechanism for it?
Not really. There's not like it's not the thing where like, you know, trauma or infection that causes it. It's just kind of it gets worse. It gets more likely with age. You know, family history of glaucoma means you're more likely to get it. You know, and then ethnicity as well. So that's why I mentioned she was a Filipino nurse.
And is it just that the sort of, so is it okay to think of it a bit like, well, the anatomy's kind of a bit dodgy because of an aging process or an underlying background, and therefore
exactly it's
more likely to happen? Okay.
Exactly. It's just, it's so there would be certain people with a faulty anatomy because of their genetics, which means they're more predisposed to this condition. But
Yeah.
I'm not aware of any particular thing
Yeah.
that causes, you can get it again in some cases, like you can get it iatrogenically, like if someone's doing an injection into the eye and then puts too much stuff in the eye, that can cause glaucoma. But those are kind of specific cases.
Yeah. And the other question I had was just about why does it cause headaches? If it's is it literally just, is it the eye increased pressure then causing
exactly
in the head in general? Is it just as simple as that, or is there some like weird like nerve, chemically induced headache or nausea and all that sort of stuff? I wasn't quite sure the link between it.
So I'm not sure if there's any specific kind of reason, but the way that would make sense to me would be that with the increased pressure in a confined space, it causes pain to the surrounding structures because of that kind of pressure mechanism. So the same way with something like increased intracranial pressure, that causes pressure on all the surrounding structures, because the brain doesn't have any kind of sensory inputs, but it's more like the muscles and the bone and the skin, that's actually what has the sensory input. So that's why when you get like an intracranial hemorrhage, like it's those things that cause the headache. So I imagine it'd be a similar mechanism where it causes pressure on the surrounding structures, but again, I'm not
that's fine. Yeah, that's fine. If that's how you understand it, that's absolutely fine.
Yeah.
I just wondering whether there was some sort of like particular ophthalmology thing, but if it's just literally just increased pressure causing more pressure somewhere else, that's fine.
Yeah.
That makes sense. Cheers.
Cool. And then any questions about any of these other ones, like corneal abrasions? Oh, and you guys were both here last time. Like, I can quickly mention the other ones if you want to. If you have any questions about any of these. So, like chalazion, blepharitis, stye, dacryocystitis. This is an important one to remember. Do you guys remember the distinction between orbital and periorbital cellulitis?
I remember that would cause the eye to like bulge because it's gone behind the septum, and that's much more severe than if it's around the eye and preseptal.
Yeah, exactly. So yeah, the orbital cellulitis looks much more severe than the periorbital cellulitis, and in this one, periorbital cellulitis, you'll get like a bit of pain and eye movement, whereas on orbital cellulitis, it will be a lot of pain, and it might be such to the extent where they can't even open their eye. So in that case, you need to do a CT to actually visualize the orbit. And yeah, it's just there's a good little table there that kind of distinguishes between the two.
Is it possible that periorbital cellulitis could become orbital cellulitis if it wasn't treated?
Exactly, yeah. So that will likely happen over time. Again, it depends on the cause. So you can get like a direct inoculation injury. So that would be like trauma on the external part of the eye, which starts as a periorbital cellulitis, but then over time it can become orbital cellulitis. That's from the outside in. But also you can get it from adjacent structures. So you can get kind of a sinusitis of your ethmoid sinus or something, and that can kind of go forward. So that can also cause a orbital cellulitis. Also, you can get hematogenous spread, so someone with like a full-blown sepsis, and there's been a systemic infection transferring to the eye, which can cause orbital cellulitis. So yeah, it depends on the cause.
Cool, thank you.
All right. Any other questions about anything?
No, that was a really good overview. Thank you so much for this.
Yeah, no, thanks a lot, mate. Thank you.
No, it's all right. Pleasure. All right. Catch you guys later then.
Okay. Cheers.
Is there any other topics that would be useful for you guys? Like any other topics in medicine, or like anything else that would be worth knowing for F1 that you're thinking about? You might need to revise, but you haven't got around to it.
Probably.
Yeah.
Fair enough.
I think personally, the thing that I'm probably rustiest on, because we've had so much teaching canceled now because of COVID, I personally struggle to remember the exams that we were taught in fourth year, like the specialty exam. So for example, like the exact process of how to like OSCE style kind of do an eye exam. Like I know the ideas behind like fundoscopy and that kind of stuff, but not actually how to do it. And we've had so much of specifically the practical teaching canceled, that those are the things that probably I'm rustiest on.
Okay.
This stuff, like, well, this is obviously really, really useful, but at the end of the day, like,
yeah, you want to be safe and do the basics so that someone
Exactly.
else will be bothered about it. Okay, I was going to cover ophthalmic exam, but I heard Mr. Basu was doing a teach on it for you guys.
Oh, I missed one of the teaching session last week, so he might have already done it. Which
Oh, right. Okay.
Yeah, his teaching was a bit more like sort of a kind of practical way of doing it. It was like the actual like real life way you would examine and
Okay.
all sort of
Yeah,
touch
yeah,
on
yeah.
that rather than sort of our level focused. It was like if you had like an SHO job as a
Oh, as a that's not that
so
useful,
like
guys. Okay.
but like useful, like really helpful, but just a kind of bit like kind of assuming that we kind of like know a lot about ophthalmology and we kind of probably
Yeah.
really. So just something a bit more kind of focused and kind of like as you say, the sort of bare minimum safe stuff would be useful. But
Okay. Well, there's not really much you need to do, to be honest. I'll just kind of tell you now. So, firstly, just examine the eye externally. So, check the eyelids, check the pupil, check the iris, check the conjunctiva, so you can pull their eyelids down as well. And then after you've examined the eye externally, then you can shine a light in the eye. So to assess the pupils, whether they're equal and reactive to light, check for RAPD. So shine it from one to the other. And if it looks like one of them is dilating when it should be constricting, then that's something might be wrong there, like an optic nerve pathology. And then you examine the cranial nerve. So we've examined the optic nerve there. You can do the eye movements. So 3, 4, and 6. And I think that should probably be about it. I can't think of anything else that you really need to know to be safe. I think that it's nice knowing like little bits and pieces. Like someone with optic neuritis will get red desaturation. So they'll literally like see something red and then say, oh, that's black. So that means they've got optic neuritis. Visual fields is a good one to assess as well. So visual fields, you basically sit someone next to you, kind of the same level, and then cover one of their eyes and bring it from the side in, and then do that all 4 quadrants, and you can get a sense that they've got visual field deficit. And I think that's about it, to be honest. That's all I'd do if I was in ED or in a medical ward assessing a patient.
Cool.
Yeah.
Thanks so much for that.
No, that's right. Right. Catch you guys later then. Hope you have a nice rest of the day.
Thank you
Thanks.
very much. Cheers. Bye.